and today's presentation is on the alteration of the skin and pathological findings. This is being done for enlightening the healthcare providers in normal and abnormal findings within the integumentary survey, especially focusing on the skin assessment. The intended audience today is the BSN to MSN nursing students at National American University. The objectives for this presentation are to better understanding of the components of the integumentary system, the normal and abnormal findings of the aging skin, subjective and objective skin assessments, and documentation of our assessment findings. The integumentary system includes the skin, which is what we're going to talk about today, the hairs, nails, and then some of the glands. The skin, which is the largest organ system in the body. I found that very interesting. It covers 20 square feet of surface within the average adult, and I also read that it was 20% of your body weight was composed of skin. The skin has three layers: the dermis, epidermis, and the subcutaneous layer. Those are depicted here in that little graph shown on the left. And the skin's primary role is to protect the body from the environment. That's a barrier to microorganisms, UV violet radiation, which is at UV light, and the loss of body fluids and the stress of mechanical forces. That's the shearing forces, the tearing, the ripping, the cutting, those forces. Subjective skin data will include past history of skin disease. Do they have psoriasis, hives, allergies? Have there been pigmentation changes? Or any changes to the size or color of moles? Excessive moisture or dryness, that's a real key feature coming up in the future. Any pruritus, which is itching, excessive or inconsistent bruising. You always have to think about that as far as elder abuse or child abuse, and it's the same way, but elder abuse as well. Presence of any lesions or rashes. Are there any medications that the patient's taking that might be causing whatever we're seeing on their skin? What occupational or environmental hazards have occurred? That could be exposure to sunlight, it could be exposure to chemicals, so on. All the subjective assessments that we're going to find, they're going to be based on our patient-centric care. Objective data. To find that, you're going to have to inspect and palpate the skin. You're looking for general pigmentation, color changes. If there's any widespread color change, that could be very significant. Pallor, erythema, and/or jaundice, all of those are important. Check the skin moisture and texture. Look for the thickness of the skin. Is there any edema? What about the mobility and turgor? You can test that, and I'll show you how to do that in a minute. Is there any vascularity or bruising to note? Echinosis, that's very important. Next, check the nails for the shape and contour, consistency, color, and capillary refill. That's going to tell you a lot about if there's clubbing, about respiratory status, blood flow. Example here is an assessment of the integumentary system. It was provided by the Ostomy Wound Management Journal, and I found that it told you how to do the procedure, what to look for that was normal or common, and as well as then abnormal. There's 2 pages to this, so that's what the next page will also be. And it goes all the way through to what is normal and abnormal. So as you see here, we get the little hands on the bottom of the page. That's just showing you that your skin can go from any color, from that light white pink all the way to a coffee colored dark brown. So when you're inspecting, you're going to be looking for consistency, that it's with the genetic background of that person. Again, the pink to coffee colored. The benign findings are going to include darker pigmentation in the sun exposed areas, which is your tanning, and dark skinned people normally have lighter pigmentation on the palms, nail beds, and lips. That's something that I find very interesting, that their hands might be white on the bottom and very dark on the top. Common benign findings are freckles, which are epithelials, moles are nevus, and birthmarks, which are tan to brown color. With geriatrics specifically, you look for liver spots on the face, forearms, and the dorsum of the hands. That's the top of your hand. Those are called senile lentiginses. I can't say that, so that's why I call them liver spots. They're small, flat, brown, benign macules that appear after extensive sun exposure on the top of your hands. That's where I have a few of mine, and I try picking them off. They come back. It's just not something, they just don't look good, but they're not harmful. Lesions, you need to evaluate the color, elevation, pattern, or shape, and that's measured in millimeters. Here it says centimeters. I'll fix that. Location and distribution, the exudate, note specific characteristics or classifications based on the type of impaired skin integrity. So that would be pressure ulcers, perineal dermatitis, diaper rash, skin tears. Skin should be intact without any suspicious lesions. Normal variations include the nevi, scars, keloids, which are usually seen with dark pigmented skin. Keloids are those scars that are the raised big bumps on the top. The striae, those are stretch marks, those like pregnant women, and then macules. Again, in geriatrics, we're looking for those cherry angiomas. They're normal, they're okay. They look kind of bad, but it's just like a red raised mole, slightly red, raised red dots, small and smooth. And then there's those seborrhea keratosis, or the liver spots, skin tags, and purpura, which is kind of the purplish spots. Normal findings, looking for smell. Cleaning for your body odors, that's pretty much simple. If they're a smoker, you'll probably smell smoke, or if they've been exposed to smoke, you'll also smell perspiration on some people. When you palpate, you want to use the dorsum of your hand, which is the top or the back of your hand. That's the mother's touch is what I call it. It's where you go like this. And mine is usually pretty close, within just a few tenths of a degree. And you want to palpate the skin bilaterally. You're looking for abnormal distributions of heat or coolness. Skin temperature, like I said, should be equally warm to touch, and then unexposed areas may be warmer than the exposed areas, or cooler, depending upon what the temperature is of the room. Mobility and target, you're going to be checking those unexposed areas, such as on the abdomen, below the clavicle, or on the forehead, which is where the skin would not have been getting leathery from exposure from the environment. The skin should rise easily and rebound instantly with no tenting if the skin trigger is good. On this picture here to the right above my head is where they're testing the skin trigger on a little baby, and if this baby is not dehydrated, it falls back down right away. Texture of the skin should be smooth and firm with just even surface, and then in geriatrics, remember, they become very thin and transparent. Think about your grandparents' hands. I mean, I remember the little old ladies in the nursing homes and how their hands were just so fragile and frail. Here's a picture of a very frail, little thin nursing home lady's hands. This happens to be the picture of one of the grandmas of a friend of mine that was recently just passed away, but it's the granddaughter holding her hand. And you can see the differences between this young child who has this firm, fluffy hand that's nice and smooth and plump, whereas the grandma's skin is extremely thin, fragile, lots of tenting, lots of sagging, and it's just the continuum of age. So here we're going to look for the degree of moisture. It should be warm and dry. Depending upon the body area, exposed areas tend to be a little bit more dry. Perspiration appears normally on the hands, face, axilla, and skin folds in response to anxiety, activity, and to the warm environment. Dark skin, normally you see dry, flaky skin, not necessarily a sign of dehydration. I'm very well hydrated and my skin is always dry. And then the thickness, it should be uniformly thin except for thick and calloused areas on the soles and the palms. That's where you have your pressure areas. In geriatrics, again, looks like parchment as the subcutaneous fat decreases. It's thinner skin seen on the dorsum of the hands, forearms, lower legs, feet, and bony prominences. Here's an example of a basic skin assessment documentation tool that was used by one case management company, and it just walks you through all the different parts of the body. It reminds you to look at the bottoms of the feet and the back as well, and then it goes over what are the abnormals and normals. Most of us work in the electronic world these days, and so these are built into electronic health medical records. Normal finding documentation might look something like this if you were doing it in SOAP format. The subjective findings, there's no history of skin disorders, no changes to pigmentation, the skin is free of bruising, rashes, or lesions. There's no work-related skin hazards, and when they're outdoors, they use the SPF 30 sunscreen. My objective findings were skin is pink with light tan noted to exposed areas, pigmentation is even with freckles noted across cheeks and bridge of nose, again a very normal finding, and there were no suspicious nevi noted anywhere. Temperature was warm to touch, skin is smooth, dry, and even, and the trigger was very good. So my assessment is the skin is warm, dry, and intact. Education provided based on those findings were continue to use the sunblock when outdoors, maintain adequate hydration, and be cognizant of any changes to the skin color or presence of any new lesions or rashes. Here is just a little cheat sheet on age-related skin disorders. It goes through the babies all the way through older adults, and then some of the things that we would find for both children and adults. So as one ages, there are many different skin ailments that are more prevalent at that stage of life. So you think of your babies with having their diaper rash, they'll have their chickenpox, measles, all those things. And then as your skin also gets older, there are things that we've shared, like insect bites, we all have that. Contact dermatitis, if we get in contact with something we're allergic to. And now you're seeing a lot of herpes zoster, which is why the adults are getting the shingles vaccination as well. Abnormal findings, again, color, that can be looking for lesions, and they use the ABCD mnemonic. When you're looking for asymmetry, so your lesions that are pigmented, they have an irregular border, their color is dark black to a variation of pink, white, red, blue, gray, and or black, and the diameter is going to be greater than 6 millimeters. You're looking for a widespread color change, pale, cyanotic, jaundice, sallow. That's kind of that green yellow color that you look just really sick. The non-blanchable erythema is seen with poor tissue perfusion, more usually within the elderly. And then in geriatrics, watch for that erythema, purpura, and bruises. Anytime you see bruises on, especially an older adult, suspect physical abuse if there's multiple bruises at different stages of healing, and or there's excessive bruising above the knees or elbows. This picture of the lady above, she has bruising to her face, she's got a broken arm, she's got multiple bruises on her hands and above her knee. She's obviously been through some big trauma in her life. Not only would you look for physical abuse in the adult, but you're also going to be looking for physical abuse at any age. Elder abuse is more widespread than we would want to think about. Abnormal findings here would be looking for lesions. You want to note the color, elevation, pattern, shape, size. Again, what I had said earlier, is there any exudate, and what are the specific characteristics about it? Pressure sores are common in the elderly, especially over the bony prominences as they lose their subcutaneous fat and their skin shears more easily. Lesions can be primary, secondary, or vascular. So we have papules, nodules, tumors, wheals, vesicles, bulla, pustules, erosions, and so on. And so depending upon what each of those is, you'll see a different presentation. And I have a slide that comes with that next. Checking for your pressure ulcers, like I said, over bony prominences. And in geriatrics, again, assess for that actinic keratosis, basal cell carcinoma, squamous cell carcinoma, herpes zoster, pressure ulcers, skin tears, and peritoneal dermatitis. Again, like the diaper rash if there's an incontinence issue. Here's a chart that shows the different types of skin lesions. It's a nice cheat sheet to have in your pocket once you're starting to do these new assessments as a MSN. So we're going to want to palpate for tenderness and surface characteristics, and then check for pulsations and blanching with any vascular lesions. Here it goes through the bullae, the macule, the nodule, the patch, papular plaques, pustules, vesicles, and so on and so forth. Types of skin cancers, again, another good cheat sheet. The melanoma up on the top left, that's the one I'll be talking about in my case presentation a little bit coming up. So abnormal findings. Smell, again, looking for those body odors. Poor hygiene or underlying, can be also underlying disease. Excessive sweating, hyperhidrosis, urine odor, incontinence, stale urine odor, that could be associated with uremia. A mousy, we had to look that up, that's a musty kind of smell. Comes with liver disease, and it's present with fetal ketonuria in our little babies. So temperature can be either hypo or hyperthermic. It can be asymmetry in our temperatures, generalized decrease in the skin temperature is seen with when you're in shock or you have an exposure to the cold. Mobility and turgor, the skin is tented for more than 5 seconds. That relates with dehydration. If there's increased turgor and tension with edema or scleroderma, and sagging is seen with excessive weight loss. The photo below is an example of scleroderma. On some fingers you'll see dark red, there's purple on others, and there's that blanching white color on others. And that's a very sad disease. It's going to be very painful. Abnormal findings again consist of the moisture. The diaphoresis could be from fever, thyrotoxicosis, or severe pain. Dehydration, that's evident in your oral mucous membranes. Your lips will parch or cracked. And in geriatrics, it's xerosis, which is varying degrees of dryness or scaling. It's cracked, fissured, marked flaking. Texture and thickness, those could be changes associated with diseases. Hyperthyroidism, it's going to be smooth and velvet-like. Hypo is going to be rough, dry, and flaky. Arterial insufficiency is that smooth, thin, shiny skin like I showed in those other pictures. And then venous insufficiency is very thick, tough skin. You see that a lot in that stasis ulcers of the lower leg. The picture below here is of that varying degree of dryness, and when I looked up xerosis, this is the first picture that came up. It's pretty profound. When I go to document my abnormal findings, there's no history of skin disorders, no changes to normal pigmentation. The skin is free of bruising and rashes, but there is a new lesion noted on the left forearm. Work-related skin hazards includes outdoors work, and patient does not use sunblock or wear long-sleeve clothing while outdoors for prolonged periods of time. Objective finding is the skin is pink with dark tan noted to exposed areas. Pigmentation, though, is even. Abnormal pigmented lesion is noted on the left forearm that's asymmetrical, has irregular borders. Colors vary from red to dark brown to black, and the lesion measures 10 millimeters by 14 millimeters, and this lesion grew to the size over a period of 60 days and has caused a burning and itching sensation. It bleeds freely when picked at or scratched. The temperature is warm to touch. The skin is dry and leathery on the arms and face from the sun exposure, and the covered areas are smooth with good skin turgor. My assessment would be suspicious area of left forearm suggestive of malignant melanoma. My recommendations would be for surgical evaluation and biopsy with removal, and photos were taken to track the progression of the disease process. And this is a picture of that malignant melanoma with the red and the black areas. In summary, the integumentary system is composed of skin, hair, and nails. It's important to distinguish between normal and abnormal findings. There are many cheat sheets that are available. And the subjective and objective skin assessments include the patient's health history, skin exposures, medications, as well as physical findings. Documentation of assessment findings must include all that is abnormal for that particular person. It's important to provide patient education as well as prompt follow-up and consultation with specialists for those abnormal findings. And as the body ages, so do the challenges that the patient's skin is going to face. So it's important to remember not all two people are alike, so individual variations must be considered. Here are my references. And again, the little hand holding by the younger age person just reminds me of that continuation of how your skin changes over time. I'm somewhere in the middle, but I look forward to the days where I can have someone hold my hand as I become very frail and fragile as this person did. Thank you very much, and I hope you learned a lot about the skin assessment and pathological findings.